The title is When Anatomy Plays Tricks, CTO Intervention in Anomalous Coronaries. When you actually do a search in the literature, there's not many of these cases. So I'm presenting a 58-year-old lady presented with exertional chest pain for about roughly 4 months. She was actually referred from a nearby hospital. She has a background history of diabetes, all the cardiac risk factors, dyslipidemia, and hypertension. She had a resting ECG, which I will show in the next slide, and her echocardiogram showed a grade 1 diastolic dysfunction with preserved LV systolic function. Ejection fraction was more than 55%. So this is her ECG, normal sinus rhythm with left axis and T wave abnormalities. So in the local hospital, she had a CT, coronary angiography, and this has confirmed a single coronary arterial trunk arising from the right aortic sinus with severe mid-left circumflex segment disease just beyond optius marginal 1, chronic total occlusion of distal left circumflex, and furthermore, there was another chronic total occlusion of the right coronary artery at the proximal segment that revealed collaterals from the distal left anterior descending artery. So this is the beauty of using CT coronary angiography when you are arranging for CTOs. So this is the first angiogram, and I basically felt that the lesion is probably here in the optius margin that is the issue. So as you can see here, everything, the whole left main system is coming from the right coronary sinus and CTO to the right coronary artery. So at this stage, what I did was only treating the optius marginal mid portion, okay, with prepared, and then finally with a DCB using a sequent please, drug-coated balloon. And this was the final result. I think at this stage it was acceptable. We've waited 10-15 minutes and there was no recoil, and I ended the procedure at this stage. So this lady, actually, I followed her up for more than a year actually, and she was actually doing quite perfectly until she came back with further chest pain. So what do I need to do at this stage? So more imaging before you take such case into the cardiac cath lab. So we did the debut stress echo, and this shows inducible, I said we did a myocardial perfusion scan for which it shows inducible ischemia of the right coronary artery segment. Took her again to the cardiac cath lab, and to my surprise, excellent results from the sequent bleeds that we have seen from the previous intervention, which was more than a year ago. So at this stage, we have upgraded to a 7 French system, okay? And we started attempting PCI to the right coronary artery. So I used multiple wires, but not many, to be honest. So using, you can see a microcatheter here. This is a Mamba Flex microcatheter. And this is my first wire, which was a Pilot 50. It didn't take me much, too many places. And then I used the Pilot 200, which took me to probably the mid-segment. The beauty here that I didn't need a contralateral injection because everything can show from the one injection. Is beautiful. Not at the time of procedure, obviously. So anyhow, at this stage, then I took a Gaia second, and I was successfully, after multiple injections, I have passed and punctured the cap and went into the distal segment. And then I took my microcatheter down, and I've exchanged to a normal Sion blue angioplasty wire. And then the fun started. So preparation of lesion preparation took me to this. So I'll tell you what I've used to get to this stage, which is slightly scary, to be honest. When I saw this, I was a bit scared. Took microcatheter because I needed to protect the ostial and the left main, obviously, which is coming just around here. So I took a guide liner at this stage. So to get to this stage, I have taken a I've taken a Perta lacrosse, which is a scoring balloon that has excellent features. Had three main excellent features. Just to note, it's a nylon based, and it's 123 nylon based wires that has a triangular shape that does great job in calcium preparation. So I didn't need to use anything further more than a scoring balloon with Aperta lacrosse, which is brilliant. Then I started started putting my stents and my balloons with the non-compliant balloons, and then putting stents. So I've ended up with 3 stents all the way up to the almost up to the ostium of the right coronary artery, and this is my final result after putting 3 stents. So coronary artery anomalies intervention is challenging, particularly in the presence of 2-vessel disease, including chronic total occlusion. Utilizing non-invasive CT coronary angiography and proper planning are key to a successful outcome. When dealing with CTOs, we need evidence for reversibility and viability, so invest in imaging. Be ready to know your equipment, and should we use mechanical support in this case? I think this is open to discussion. I'm more than happy to discuss, because I think the question here, obviously, I mean, this lady, despite having a normal LV function, obviously the main worry still was the left main and the whole thing. So a big question regarding whether we should have used mechanical support or not. I'd like to hear and share voices and experience. And I'll stop here and thank you very much for listening.
Thank you.